Jet's implant training. Today we're going to be doing a demo of a placement of a zygomatic implant on one of our patients. Here we've taken a DICOM and we've actually converted it into an STL and printed it. So this is something that's very similar to what we do in our hands-on cases. You can actually send us a DICOM, we will convert it to STL, and then we'll print it so that you can actually do your surgery on your patient. So typically when we're doing a zygomatic implant, this case, severely atrophic maxilla, typically very minimal anchorage points, very difficult to do a traditional all-on-4 on this case. So we're usually anchoring to the zygomatic arches here. So when we're placing our implants, we're going to be placing in these areas here. Typically when I flap these cases, what I'll do is we'll need to make sure that the tissue moves all the way back here. So we have to create some releases. So typically what I'll do is I'll do a crystal incision. And I'll just draw this with the pencil. And I'll do a vertical release in the anterior right at the midline. Then after that, we'll also take our incision all the way back to the pterygoid region. Usually when we're doing these cases, we're also placing some pterygoid implants in there. So we want to make sure that this area all the way up back to the hamular notch, there's an incision there. And then we'll also, usually what I'll do is I'll run my finger right in the back here and I'll feel the zygomatic protuberance or the malar process. And usually I'll make my vertical incision about 1 centimeter in front of that. So typically in like the first molar region area of the arch is where we're making our other vertical release. Then typically what we'll do is we will raise our flap, and as we're raising our flap, I like to use a blunt-ended instrument. And basically we can use our areas where we have our releases to start our flap. And then what I like to do is we'll use a little bit of gauze, and we'll actually, the best way I've found to raise flaps is you'll press with the gauze. And as you press with the gauze, you can put some real firm pressure, and that pressure will help you move that flap all the way up. When we're flapping these cases, typically what we're doing is we want to flap. I'm going to mark some anatomic landmarks here. This is our malar process here, and this is our zygomatic arch. So if I hold this close up to the camera here, you can see. So this area right here, where the zygomatic arch intersects the malar process, makes an X. This is actually going to be where we want our insertion point for our zygoma. So typically when we're reflecting our flap, we like to see that, and we also like to see the zygomatic notch, and that's back here. So this is all the way back far here. So when you're reflecting your flap, you really have to reflect a good flap. If you don't get a good vertical release over here of at least 1 centimeter, it's going to be very difficult for you to reflect your flap, or for you to envision and see what you need to see. So the nice thing about a zygoma is it's done completely where you can see the entire process. So we've identified our malar process, we've identified our zygoma, and usually what we'll do is, even in the surgery, we'll take a surgical pencil, a sterile pencil, and we'll mark that when you first get started. I think that's a great way for you to have a reference point. Usually right here, just past that X, just distal to it, you'll find the insertion point of the masseter muscle. And typically that insertion point for the masseter muscle, what I'll do is I'll take probably about 2 to 3 millimeters and just scrape along the zygoma so that I can release just a little bit of that masseter. So what we're not doing is we don't take a scalpel to that, because it will bleed excessively. But my point for that is to just get that masseter out of the way so that while we're drilling, we don't accidentally hit this area here and cause a lot of bleeds. So typically what we'll do is, once we've marked our spot, We'll start with a round diamond burr. I just use this on a 20-degree handpiece. And we'll make a osteotomy in that spot until you'll actually drop in to the sinus. You'll feel it once you've dropped into the sinus. Then I like to take a small curette and basically just make sure that there's no Schneiderian membrane around the area. So we'll just elevate that Schneiderian membrane. So once we have elevated the Schneiderian membrane, now we can move to our barrel diamond. And this barrel diamond is designed to not be end cutting. And basically what we do is we place the tip right inside of that area where we did the osteotomy. And then what we'll do is we'll lay that flat onto the malar process. And basically what we're doing is we're trying to follow this line here so that we follow the same angulation. Now, depending on how far back, if you're able to place a nice pterygoid implant in there, you may want to come a little more anterior with your zygoma for access points. So I can either angle my zygoma like this, or I can access like this a little bit flatter if I have a posterior implant. In this particular case, we're going to go and take this a little bit distal here, because we don't have a ton of pterygoid space to work with. So what I'm doing is I'm just generally laying this burr down to create a channel in the bone. Sometimes we'll use that little round burr, that round diamond, to kind of help get it started. And I'll use copious irrigation when we're doing this in the mouth. And I'll typically rock it back and forth here. And my goal with this one usually is I'll place it until the entire barrel is buried, and then I'll check my angulation to make sure that I am clear of the orbit. So in this case, the way that we do that is we have a special guide called the Zygo. This was invented by Sewon Oh, who's a great zygoma guy to learn from. But basically, this guide will just make sure we're clear of the orbit. We place the diamond barrel inside of it. And this is a really, really nice tool for us to use clinically, because as the diamond barrel fits in, then we can go ahead and close this. And what we're doing is, from a patient perspective, if there's skin over this area, we're feeling in this area where this little point is matching. So if we feel this area where the point is matching, we can actually feel the zygomatic notch, and we can also feel if this was a little more vertical, we could feel if this was hitting the orbit. So what we're doing is we're putting our finger right where this is touching. So this we get a palpation idea of where the orbit is. This angulation tells us we're very clear of the orbit, so we're in a safe position to place our zygoma. In this case, I'd probably just shallow it out a little bit more so that we can get a nice exit for the zygoma a little bit further interior here. So I'm going to shallow it out just a little bit more, and then we'll start our osteotomies. Okay, so we're going to go back in with our diamond and just shallow this out just a touch more. If you go little by little, it'll create a nice little channel there that you can follow with your burrs. So we're going to grab our burr here. And the first burr we'll typically use is basically just a lance drill. It will fit right inside of this osteotomy that we've created. And we're going to go ahead and advance it. We're going to need a little longer burr here for this one. We're going to advance it until we get through the cortical plate. So as we go here, you should see the tip come right out the buckle, just like this. So as soon as it goes through the buckle, we'll stop, remove our burr, and move up to the next size burr. So here's our second burr in the sequence. And this burr is a 2.75 burr. That first one was a 1.8 burr. 2.75 burr will go into that osteotomy, just following the same course that the diamond burr barrel helped us create that channel with. So that's our second burr. And then we're going to go with one more burr because this is a model. Usually in the mouth, I will just try my implant in with that. And usually it's pretty good, but we're placing a 4.0. So in this case, I'm going to go up to a 3.0 implant because the models are a little bit brittle. So I'm just creating a little more of an osteotomy there. And we're going just till the tip comes out. And you can see this clinically. When you have this retracted with your hand, you'll be able to see the tip of the drill bit go through. So once we've created our osteotomies, now we're going to go ahead. We can measure the site. Typically what we'll do is we'll place this little measuring tool inside of the osteotomy, and then I'll place it until I feel it drop into the zygoma area, and there's a little notch on the end of it that I'll pull. And when I pull that notch, I can tell exactly how long this area is. So typically, when I can rotate this so I can show you, there we go. This little notch right here is my measuring area. So this has a measurement of 50 millimeters. So typically I'll take about usually 2 to 5 millimeters off depending on how deep I want that placed. So I'm going to place a 47.5, or actually in this case a 45. So I'll get a 45 millimeter implant. And typically when we're placing our implant, we'll go ahead and use our insertion tool. And we'll introduce that into the osteotomy right through that channel that we created. And typically what we'll do, I put a little bit of pressure right on the neck of the implant as we insert. And when we go in, we'll feel our resistance, and usually I'll back off. So I'll go in about a turn and then back off about a quarter turn. So as we're doing that, we should be progressively placing the implant deeper and deeper into the osteotomy until we achieve nice cortical stability and we achieve our platform height that we'd like to see. So now we've got nice cortical stability here. Platform height is in a good position here, so that way you can see exactly where we're at. Okay. We can actually insert this one just a little bit more. So typically if I had a longer implant in here for the course of the demo, we can engage that cortical plate right there. Okay. Very good.